Next, we are privileged to have Professor Dr. Ismail Jatoi sir presenting on topic Estrogen receptor-negative and triple-negative breast cancer, epidemiological and surgical considerations. Professor Dr. Jatoi is currently serving as a professor in the Division of Surgical Oncology and Endocrine Surgery at the University of Texas Health Science Center, USA. Thank you, sir.
Well, thank you very much. And again, I want to thank the organizers and Professor Chowdhury in particular for inviting me to this conference. So Professor Chowdhury asked me to talk about ER-negative breast cancer, triple-negative breast cancer, and the surgical management of it. So the surgical management actually doesn't change that much when you compare to other breast cancer subtypes. What does change, of course, is the sequence of surgery in relation to drug therapy. So for the triple negatives, there's now evidence, and I'll mention this at the very end, that in fact, chemotherapy, immunotherapy with pembrolizumab, it results in about a 5% absolute benefit in terms of survival, overall survival. So there's a benefit, and there is some evidence of that actually going back to NSABP 18, that we would see a benefit to neoadjuvant chemotherapy compared to adjuvant therapy, and I will talk about that. NSABP 18 was interpreted as a negative trial, showing no benefit to neoadjuvant compared to adjuvant. But if you really look back at NSABP, there is some evidence to suggest that there was a benefit in that trial to neoadjuvant in premenopausal early breast cancer. So estrogen receptor negative breast cancer is defined as breast cancer that lacks expression of the estrogen receptor. And triple-negative breast cancer lacks expression of estrogen receptor, progesterone receptor, and the human epidermal growth factor receptor 2. Now, in the United States, we have the Surveillance, Epidemiology, and Results Database, SEER database, which tracks U.S. national trends in cancer incidence and mortality. So if you look at SEER in the United States, approximately 23% of all breast cancers are reported as ER-negative, and about 10 to 15% are reported as triple-negative breast cancer, 10 to 15%, 23% of all cancer ER-negative. So the majority, 77% of breast cancers in the United States, in the SEER database, which is the national database, is estrogen receptor positive. Now, what's interesting is that the incidence of estrogen receptor positive breast cancer is higher in parts of the world where mammography screening is widely utilized. So in those areas of the world where there's extensive screening, you see higher rates of ER-positive breast cancer. So the proportion of ER-positive to ER-negative increases in areas of the world where there's a lot of mammography screening. Now, why is that? Well, the reason is that ER-positive is an indolent disease. It's a slow-growing cancer. The ER-negative is a more aggressive cancer. So there's a phenomenon in screening known as length bias. So if you can imagine yourself on the bleachers of a football field, and you've got a camera, and you're taking a picture of people running across a football field, who are you more likely to catch in the eye of the camera, the slow runner or the fast runner? And the answer is you're more likely to catch the slow runner. The slow runner spends a greater length of time running across the football field and is more likely to be caught in the eye of the camera. Well, the same principle applies to mammography screening. If you're getting a mammogram every year, every 2 years on women, it's the slow cancers that are more likely to be caught and detected in the eye of the mammogram machine, the ER-positive breast cancers. So in those parts of the world where there's a lot of mammography screening, the ER-positive breast cancer rates increase as mammography screening is implemented. Now, that's not necessarily a good thing, because a lot of the ER-positive cancers that we find that are being detected as a result of mammography screening in the Western world, we attribute to overdiagnosis. In other words, many of these cancers would never have become clinically relevant, and many of these cancers pose no threat to life, and many of these cancers would never have been detected in the absence of screening. In fact, a study by Blyer and Welch, which was published in the New England Journal of Medicine, I think around 2012, argued that about 75,000 women in the United States, this is in 2012, or about 30% of the all breast cancers, were overdiagnosed excuse me, as a result of mammography screening. So mammography screening can result in overdiagnosis, can result in overtreatment, and ER-positive rates increase in populations where there's a lot of mammography screening. Now, the other interesting thing about ER-negative versus ER-positive is that the ER-negatives, which I will say also, we equate to high risk, tend to occur earlier in life with a peak age of onset at about 50 years. Whereas the low-risk tumors, again, we're looking at the US population trends, the low-risk tumors, the ER-positive tumors, tend to occur later in life. The peak age of onset is about 70 years. So the average age for breast cancer is about 62 years, but the ER-negatives, the peak occurs at about 50 years, and the ER-positive about 70 years. Now again, just to emphasize, the triple-negative breast cancers obviously have a worse prognosis, and we now have good evidence that neoadjuvant therapy, chemotherapy with pembrolizumab, based on the Keynote 522 trial, has become the standard of treatment and is now widely used in the United States, except for very small triple-negative tumors. There's about a 5% overall improvement in survival with neoadjuvant chemotherapy plus pembrolizumab. Now, I want to direct your attention to the graph on the left. This is an incidence curve. The lower graph, I don't know if I can show this. Maybe, okay, sorry, let's. Okay. The lower graph shows the ER-negative. Notice it goes up dramatically, and then it plateaus off at about age 50. The next graph up higher is the ER-positives, where you see a steady rise in incidence until about the age of 70, and then you're kind of seeing a plateau off. And the third graph in the top is overall. So what you see is that the incidence curves are very different between ER-negative and ER-positive. The ER-negatives tend to occur earlier in life, plateau out after about age 50. The ER-positives tend to occur later, continue to advance past the age of 50, incidence keeps going up, and they reach a peak at about age 70. Now, you can also do what's called a age frequency distribution, where you look at raw numbers, and that's what that second graph shows, but I'll talk about a little bit later in the next graph, in the next slide. And then the lower one shows the hazard plots, which I'll talk about as well. So the point here is that the incidence rates of the ER-positive, the incidence curves the ER-positive, and the incidence curves the ER-negatives are very different. The ER-positive rates peak at about age 70. ER-negative rates peak about age 50. ER-negatives are more common in younger women. ER-positives are far more common over older women. Overall, of course, ER-positives are more common in terms of tumor type. This is the age frequency distribution. You see that there's actually there's a bimodal plot that emerges when you plot age frequency. Now, the frequency distribution looks at raw numbers. So the reason it's low, below 20, is because breast cancers rarely occur before the age of 20. And the reason it drops off completely by age 100 is because women aren't alive at that point. So the numbers are very low at 100. But what you see is that it's a bimodal distribution. And the peak on the left represents the ER-negative. The peak on the right represents the ER-positive. Again, this is from the SEER database. Now, I'm going to talk about something which I think is, to me anyway, very fascinating about ER-positive versus ER-negative. And what this suggests to me, these age interactions, is that we're really dealing with two very different diseases. We tend to look at breast cancer as very monolithic. I would argue that based on the evidence that we have, that ER-negative and ER-positive are very different diseases. They perhaps originate from different stem cells that have different pathways of development. So an age interaction refers to differences between categories of patients according to age. Okay? Now, if the direction of the effect in the same direction, we refer to that as a quantitative age interaction. For example, if a risk factor increases the risk of breast cancer in younger and older women, but it has a greater effect in increasing breast cancer in older women, we would call that a quantitative age interaction. The effect is increasing risk in both groups, with a greater effect in increasing risk in the older group. A qualitative age interaction is different. Qualitative age interaction means that the direction is different. So in one group, a risk factor may increase risk, and in another group, it may decrease risk. That's a qualitative age interaction. So qualitative age interactions are very uncommon. And when you see a qualitative age interaction, a lot of epidemiologists would argue that you're really seeing a sign that there's two different diseases at play. What we see with ER positive and ER negative are qualitative age interactions. Not always quantitative, but in many instances qualitative, and I'll talk about that. So in breast cancer studies, the age interactions really reflect differences between the ER negative cancers, which occur more commonly in younger women, although ER positives dominate, and the ER positive breast cancers, which occur far more commonly in older women. So the age interactions in breast cancer studies reflect the ER negative versus ER positive differences. So again, quantitative age interactions refer to instances where the size, but not the direction of the effect differs according to age. That is, a risk factor may have a greater effect on one age group when compared to another age group, but in both instances, it has the same effect in the same direction. Either it increases risk or decreases risk in both age groups. But a qualitative age interaction refers to situations where the direction of the effect is reversed according to age group. That is, a risk factor may be associated with an increased risk in one age group, but a decreased risk in another age group. And that's a crossover effect. And many epidemiologists would argue, I'm not an epidemiologist, I'm a surgeon, but many epidemiologists would argue that qualitative age interactions may suggest that you're really dealing with two different diseases with different natural histories, perhaps originating from different stem cells. So let's look at examples of qualitative age interactions in breast cancer studies. So nulliparity, obesity, and use of oral contraceptives, I apologize for the typo error there. Nulliparity, obesity, and use of oral contraceptives all reduce the risk of early onset breast cancer, but increase the risk in older patients. A qualitative age interaction. There's a trial that was undertaken by Umberto Veronesi, the Italian breast surgeon oncologist in Italy, looking at fenretinine, which is a vitamin A analog, as a means of preventing breast cancer. And what's found in that trial was that fenretinine reduced breast cancer risk in premenopausal women, but it increased breast cancer risk in postmenopausal women. Another example of a qualitative age interaction. Again, younger patients, higher rates of ER negative, older patients, higher rates of ER positive. These interactions suggest differences between ER negative versus ER positive. Mammography screening. Now, you're all familiar with the debate about mammography screening. It benefits older patients, does not benefit younger patients. It actually goes beyond that. If you look at the 9 mammography screening trials, I guess there were 6 trials, initiated between 63 and 80, 9 overall, but 6 between 63 and 80. If you look at the trials initiated during the years 63 and 1980, there was a non-significant increase in breast cancer mortality in women under the age of 80 at the start of those trials, and a decrease in mortality in older women. And Cornelia Baines, who described this effect, labeled it as a mortality paradox. But again, it's an example of a qualitative age interaction with respect to age and breast cancer risk. And it, again, implies that the ER negative and ER positive breast cancers are really very different diseases, perhaps originating from different stem cells. Finally, the NSA-BP18 trial randomized breast cancer patients who received adriamycin and cyclophosphamide, AC, either before or after surgery, and found that for younger women, younger than age 50, survival was better among those receiving postoperative chemotherapy, whereas for women over age 50, survival was better for patients receiving postoperative chemotherapy. So for the younger women, survival was better for women receiving preoperative chemotherapy, whereas for women over the age of 50, survival was better for women receiving postoperative chemotherapy. Overall, there was no difference in outcome. So the overall results were published as negative. If you go back and look at that trial, what you see is that there was a qualitative age interaction. The younger women who got preoperative chemotherapy benefited. The older women actually had a slight increase in terms of outcome, and so there was a qualitative age interaction. Norman Woolmark, who actually was the PI of that trial, commented on that in the NCI monograph in 2001. He commented on the fact that there was a qualitative age interaction. Now, Professor Dizon mentioned this. This is a graph that we published. Bill Anderson and I published this back in 2010, looking at the SEER database. The middle graph is all cases of breast cancer. The upper graph shows ER negative, and the lower graph shows ER positive. What this is a hazard plot. And it's looking at the risk of death after the diagnosis of breast cancer. And what you see is that for the ER negatives, there's a very sharp increased risk of breast cancer in the first 3 years. With the ER positives, you don't see such a sharp increase. And what's really fascinating is that at 8 years, there's a crossover. At 8 years, there's a crossover. Again, a qualitative interaction. There's a crossover so that the ER negative crosses over the ER positive. So what I tell my patients with ER negative is, yes, you have a higher risk of recurrence in the early years. But if you make it to 8 years, your risk of recurrence is actually less than that of your counterparts who are ER positive. So there is a silver lining to being an ER negative patient with breast cancer. That is that if you get to 8 years, you're probably not going to recur. The risk of recurrence after 8 years is very, very, very low for ER negative patients, but it remains about 0.5% per year, a little bit higher than that in this graph, for the ER positive patients. Now, there's a lot of discussion in the early 90s and early 2000s about the fact that breast cancer mortality rates had started to decline in the United States for the first time. So the mortality rates were tracked since about 1950. From about 1950 to 1990, the mortality rates in the United States were flat. There's no change at all. Then suddenly in 1990, we started experiencing for the first time a decline in breast cancer mortality. So Bill Anderson, Phil Rosenberg, and a few of us at the NCI looked at the mortality trends according to ER. Now, ER results weren't really available in SEER until about 1992. But if you look at the graphs, what you see on the left side is the overall decline in breast cancer mortality in the United States, which started in 1990. What you see on the right graph is the blue represents the ER positive, the yellow represents the ER negative. What you see is that the early years of that decline mortality, the benefit of the decline mortality was almost entirely attributed to declines in mortality in ER positive breast cancer. There's no benefit of interventions on ER negative. Now, what caused this decline in mortality? Well, there are a couple things that happened in the 1980s that resulted in the decline initiated in 1990. First of all, of course, mammography screening started in the United States in 1980. And as I said earlier, mammography screening preferentially detects ER-positive breast cancers. So the patient with ER-positive breast cancers benefited, the patient with ER-negatives did not from mammography screening. The second thing is that tamoxifen, endocrine therapy, was introduced in the mid to late 80s. It takes about 3 years to see the effect of tamoxifen on mortality. And so what we're seeing in 1990 is a decline in breast cancer mortality attributed to the implementation of tamoxifen as adjuvant therapy for breast cancer and the implementation of mammography screening around 1980. And both those interventions primarily benefit patients with ER-positive breast cancer and not patients with ER-negative breast cancer. And I'll talk a little bit more about that at the end when I talk about the racial disparity, which I'm going to talk about now. So in the United States, the age-adjusted breast cancer mortality is about 40% higher for African-American women when compared to Caucasian women. So there's a huge gap in mortality in the United States. African-American women are much more likely to die of breast cancer when compared to Caucasian women. Now again, this racial disparity emerged in the 1980s. This racial disparity emerged in the 1980s. If you go back and you look at the mortality rates for black women were actually lower in the 70s when we were tracking mortality. But all of a sudden, then in the 80s, we see this emergence of the mortality disparity. And this is highlighted in this graph. So if you look at the blue represents mortality in white women, Caucasian women. Red represents mortality in black women. And what you see, starting in 1970, is that black women, actually African-American women, actually had lower mortality rates than white women, Caucasian women, until about 1980. So 1970 to 1980, there were lower mortality rates among the African-American women compared to Caucasian women. Then all of a sudden in 1980, something very dramatic happened. In 1980, we see this splaying out of the mortality rates. So mortality rates in black women compared to white women, a huge gap developed. It wasn't there before 1980. Also, we did what's called an APC analysis, age period cohort analysis. this analysis we undertook when I was in the Army back in the around early 2000s. In age period cohort analysis, you can tease out if the effect of this emergent mortality disparity was attributable to differences in risk factors, differences in age, or the intervention of new treatments. And when we did the APC analysis, what became evident was it was a calendar period effect. It wasn't a birth cohort effect. It was a calendar period effect, meaning that was the implementation of new treatments that led to the emergence of the disparity. So the introduction of mammography screening, which preferentially picks up and improves outcomes in ER-positive patients, and tamoxifen, which benefits patients with ER-positive breast cancers. African American women have much higher rates of ER-negative breast cancers, and so they didn't benefit from these interventions. Caucasian women have much higher rates of ER-positive. African American women have higher rates of ER-negative. African American women with high rates of ER-negative breast cancers did not benefit from the introduction of tamoxifen in the 1980s, from the implementation of mammography in the 1980s. Caucasian women with high rates of ER-positives did benefit. So the introduction of novel medical intervention in the 1980s, tamoxifen mammography screening, likely triggered the emergence of the racial disparity in breast cancer mortality. Both tamoxifen and mammography screening primarily benefit patients with ER-positive breast cancers, and Black women have higher rates of ER-negative breast cancers in the United States. Rates of ER-negative breast cancers among African American women is 65% higher compared to that of white women, and the rates of triple-negative breast cancers are 81% higher for Black women compared to white women. And also, of course, there's the other issue. Black women often lack access to these interventions because they often lack health insurance or had inadequate health insurance coverage. So socioeconomic factors obviously also had a bearing in the emergence of the racial disparity in breast cancer mortality between Black and white women that emerged in the 1980s. Now, I'm going to finish by very briefly talking about the Keynote 522 trial. So the Keynote 522 trial randomized patients to either pembrolizumab and chemotherapy versus placebo and chemotherapy. Okay, and again, this is in the neoadjuvant adjuvant setting. And what the trial found is there's an overall 5% improvement in survival in patients who receive neoadjuvant pembrolizumab and chemotherapy. And if you look at the subgroup analysis, the benefit essentially applies to most of the subgroups. There are a few instances here where the confidence intervals cross across zero, but there's clearly a benefit in most subgroups, and there's a 5% benefit. Now, this was a secondary endpoint. It was not the overall survival was not the primary endpoint in the trial. It was a secondary endpoint in the trial. But nonetheless, it's a very significant finding, and points to the fact that there's now benefit to giving neoadjuvant chemotherapy with pembrolizumab in improving overall survival in patients who have triple-negative breast cancer. So just to summarize, younger women have higher rates of high risk ER-negative breast cancers, and old women have higher rates of low risk and ER-positive breast cancers. So there is an age effect here. There are numerous examples, as I pointed out, of qualitative age interactions in breast cancer. And these qualitative age interactions suggest that ER-negative and ER-positive breast cancers should perhaps be viewed as different diseases derived from different pathways, and perhaps they may originate from different stem cells. These are very different in terms of risk and outcomes. Population-based mortality statistics suggest that we made greater progress in treating ER-positive breast cancers. Again, this is the US population database this year. And we made far less progress in treating ER-negative breast cancers. So the decline in breast cancer mortality that emerged in 1990 in the United States, mortality rates have been flat, for about 40 years before that. But the emergence of the decline in mortality is largely due to improvements in diagnosing and treating ER-positive breast cancer, mammography screening, and endocrine therapy. The emergence of the racial disparity. African American women have higher rates of ER-negative breast cancer. The emergence of the racial disparity is due to the fact that African American women have high rates of ER-negative breast cancer, and they have not benefited from the better treatments and screening that benefits patients with ER-positive breast cancers. There are also socioeconomic factors at play. African American women have less access to treatments because of lack of insurance and undercoverage from healthcare insurance. And finally, I want to emphasize that we now have a treatment regimen that has actually been shown to reduce actually been shown to improve overall survival in triple-negative breast cancer, and that's neoadjuvant systemic therapy, which involves chemotherapy plus pembrolizumab given prior to surgery. So the real message about surgery is the sequencing of treatment. Okay, so traditionally, surgery was the primary therapy and drug therapy was the adjuvant therapy. I would argue that for triple negatives, we can say that systemic treatment should be the primary therapy and surgery should be the adjuvant therapy. I think that's what's become apparent from the results of Keynote 522 and the other trials that are now in play. Thank you very much.